So moving on, I'm really pleased to introduce and to welcome Associate Professor Gabriel Haeusler. Gabrielle is a Paediatric infectious disease physician and clinician scientist who's got particular interest in pediatric infectious disease and infections immunocompromised and research program seeking to optimize the management of infections in cancer in children through enhanced surveillance of fungal infections, implementation of evidence-based care pathways, and evaluation of novel diagnostics. And I'm really pleased that you've come up from down south to honour us. Thank you so much. Well,
Thank you very much for those kind words, and thank you so much for the introduction. This has been such a great meeting today. Been great to catch up with old friends and meet new friends and hear about everyone's research. Today, I'm going to run through some data that we've been collecting over a good period of time. That is really focused on optimizing the management of febrile neutropenia in pediatric patients. And why febrile neutropenia? Fever is one of the most common causes of emergency department presentation in kids with cancer or stem cell transplant, and similarly in adults, and the most common cause of unplanned hospital admission, or one of, in these patients. And there were, when we started this large piece of work, there were international data and guidelines to suggest that risk stratification was important for these patients, that they weren't all at same risk of severe infection, and many kids were at lower risk of infection and could be safely managed with reduced intensity treatment, oral antibiotics, and home-based care. So for the next 20 minutes or so, I just wanted to take you through the process we have gone through over the last few years to generate these data. So starting in 2016 was really very much just trying to understand what was happening across the country. We used that information, and I'll talk you through this as well, had to develop guidelines and implement care pathways, and using all of that information and then building on the data that we collected in that knowledge generation phase, we implemented low-risk care pathways and evaluated the impact of those. And like with any good research project, you get more questions at the end than answers, and that identified a lot of additional research gaps, particularly in the Australian context, and that's informed some other trials that we're running now, and I'll run through ones that are looking at antibiotic duration in the higher risk patients. We were able to use these databases to look at the impact of time to first dose antibiotic on outcome, and just answering some really simple questions as well in these patients. And what is the role of daily blood cultures, and what is the additional benefit of adding that aminoglycoside into patients with febrile neutropenia? So starting with the initial study opened in 2016. So this was a prospective observational cohort study that enrolled patients across all 8 paediatric tertiary cancer centres in Australia. And really it was designed to validate existing risk stratification rules, but just to understand what was going on in our patients and what the outcomes were. And again, just some simple data initially. So we wanted to work out, what were the causes of fever in these patients. And you can see that 55% of all comers, so this is solid tumour patients and leukemia patients, so about half of the patients were leukemia, and solid tumour is a bit less than that. It was quite representative of the paediatric cancer cohort, and not much has changed in the cause of their fever since the original EORTC studies that from the 1980s and the 1990s. So at least half of them don't have an identifiable infection. The one difference that we are seeing is that there's more micro-defined infections as opposed to clinically defined infections compared to those earlier cohorts, and probably just representative of the availability of molecular testing to capture those viral illnesses. Regarding the type of, apologies for my slides have mucked up a little bit. So regarding the types of bloodstream infections, so about half of them were gram negative. We were also able to look at how long were these children febrile for, and this is all data that's gone on to inform other studies. So the median duration of fever in these patients was 12 hours, and the traditional prolonged fever. A quarter of patients are having fevers greater than 48 hours, and it dropped down to about 15% greater than 72 hours. And outcomes were really good. Sorry, I should have checked these slides were going to work. I'll have to remember. So severe sepsis was very low, so about 2%. ICU admissions around 1% in all these patients, and mortality, only 4 patients died out of the 858 that were enrolled in this study, and they were all non-infective causes. So generally, pediatric febrile neutropenia patients do really well, and half of them don't have a severe infection documented. The study was, as I mentioned earlier, was designed to validate existing risk stratification rules. There are, I think, now over 20 pediatric febrile neutropenia risk stratification rules, as opposed to adult land, where there's that 1 or 2 rules, MASC rule, that is used more broadly. And you can see that the AUC, so this is a measure of the discriminatory ability of these clinical decision rules. You want, an AUC of 0.5 is basically a roll of the dice. So you want to avoid a rule that's only got a low AUC, and ideally you're wanting something above 0.7 at least, but at least ideally above 0.8. So you can see that in our population, the AUC of the more common rules that are used across the world actually overall didn't perform that well. So because there were already 20 plus rules in existence, we did some work to recalibrate an existing rule that had the best performing balance between sensitivity and specificity and AUC. And we landed on a Swiss Paediatric Oncology Group rule that was designed to predict adverse outcome. Interestingly, they had high hemoglobin. The higher the hemoglobin, the higher the risk of infection, which is a bit counterintuitive, but that dropped out in our model as being predictive of infection in our cohort. You can see it has 3 variables, a 1 or a 0, and you can score anywhere between a 0 and a 3, 0 being lowest risk, 3 being highest risk. And however, despite our best attempts to recalibrate and we wanted to avoid sort of overdoing it and overfitting, our AUC was still only modest at best at 0.64. But you can see when we're breaking it up, depending on where we make the cut, the sensitivity is quite high at a 0. However, the specificity is going to be low in that setting, and we're not going to have many patients that fall into that group, only 84 out of the 858 that would be identified as low risk. So rather than just have a rule that was simply low and high risk, we were able to implement and develop a pathway that used that spectrum of risk and took that into consideration, and really just thinking that the 0s have got a very low chance of a bloodstream infection that ultimately we're most worried about at 3.6%, and the 3s have a 1 in 4 chance of having a bloodstream infection. In addition to, and I'm going to keep apologizing for my slides, sorry about this. In addition to the quantitative data on what was happening with febrile neutropenia around the country, we also use this opportunity to get some qualitative data and try and understand patients' and clinicians' perspectives of being in hospital. And there's a really great quote from an adolescent child that you can't really read, but basically, hospital sucks, I don't want to be here. And a parent highlighting that their child does better when they're managed at home. However, it really is important and quite really relevant for many of these patients that they can get really sick quickly. They can look okay 1 minute and terrible the next, and they're not all at the same risk of infection. And we really need to take that into consideration, and people's concern that what would happen if they went home too early and something terrible happened at home. And families have certainly seen that happen to their own children, and many experienced oncologists have seen that happen to patients. So we really need to take all that into consideration. Beyond just that qualitative aspect of attitudes towards home-based care and risk stratification, we measured that in more of a quantitative fashion and added on parent and carer and child quality of life forms at various phases of their febrile neutropenia journey. And you can see in the orange line there, that's the median child quality of life of the participants in this study. The dashed line at the top is the national average for all children. The 1 is the greatest state of quality of life ever. A 0 is a state worse than death. And really sobering, I think. You can see how low during a FEBNUD episode a child's quality of life is with cancer. It improves a bit after 7 days of going home after their FEBNUD episode. And at 30 days is probably back to the baseline is where they sit throughout their cancer journey. So these kids are not feeling very happy at all. So in that knowledge generation phase, the conclusions that we made from that really informed the next phase of the work that we did was that more than 50% of FEBNUD episodes don't have a documented infection. Overall outcomes are excellent with very low ICU admission rates and mortality. We've got some concrete data now to show that hospital admission negatively impacts patient quality of life. And the existing clinical decision rules and the rule that we recalibrated and developed have moderate discriminatory at best, and they shouldn't be used in isolation. So taking all that information and some pilot data from the Royal Children's in Melbourne, we were able to develop a low-risk febrile neutropenia pathway. So this pathway doesn't really change anything with that initial recognition and management. It's really after the patient's had some time in the emergency department or even gone up to the ward that they would be risk stratified, and it's a sort of spectrum from 0, 1, 2, and 3. Because the rules don't perform perfectly, and certainly far from it, we added in this additional safety net criteria. So we intuitively, patients that had severe sepsis when they came in but might have scored a 0 or a 1 wouldn't be eligible to go home. They didn't have an infection requiring inpatient care, kind of obvious things, but additional things that, they weren't in induction ALL or they didn't have relapse or uncontrolled disease. And based on the scoring system and correlating it with their rates of bloodstream infection, we developed some recommendations about the minimum duration of hospital stay before they were eligible to go home. Again, packaging all this up into a toolkit with resources for all the sites that were involved in the implementation phase, with a policy where they could use the Oz rule or they could insert their local rule if they wanted to use something different, as well as organisational ready assessments that just went through all the different components that hospitals needed to think about before implementing a change to practice. And on EverQ, there's a febrile neutropenia education package, and we updated that to include risk stratification. And so then moving into the prospective implementation study. So it was all the same sites that were involved in the knowledge generation component of the study, continued on quite seamlessly, and we were fortunate to get funding for this study as well, where we started to enrol patients into the program and evaluate the clinical, economic and quality of life impact of a new model of care. And so these data are a little bit old. I'm still waiting for some updates to come through, but you can see that these down the side are the, key performance indicators that we use to monitor the clinical impact of the low-risk FEBNUD program. We wanted to know what proportion of patients were transferred home, what their length of stay was in hospital before going home, and we wanted to understand what the missed opportunity rate was. So the kids that were eligible to go home met all the safety net criteria but never got out the door before that 48-hour window. We wanted some safety measures as well. So what were the unplanned readmission rates? On the local pilot, there between 13 and 15% of kids required readmission for various reasons. Some were, potentially could have just gone straight home. Some kids needed to come in for blood products and things. And any severe adverse outcomes on the program, coming in, I always, when I educate about the program, is a readmission is not a failure, but a readmission in an unwell child that can't re-access the system or ends up straight in ICU, that would be classified as a failure. And then we looked at total in-hospital bed days saved, equivalent to the time that the child would have spent in hospital. The hospitals could elect to send children home on oral antibiotics, a mixture of oral or IV, or all intravenous antibiotics, and utilise HITs. And interestingly, the two sites that were only oral antibiotics tended to have a higher proportion of children transferred home and much lower rates of missed opportunity, and reassuringly, no adverse outcomes in that group. Regarding the economic impact, so this is a cost utility model, so it looks at the incremental effectiveness on quality of life and the cost of a program. The holy grail of implementing a new program is to be in that bottom, your right corner, and you can see that most of our simulations, was over 65% of the simulations for both the healthcare system and the patient were more effective and less costly. And when we just compared the mean cost of in-hospital care to home-based care, you can see significant differences to be managed in hospital versus at home. So much cheaper to be managed in home for the healthcare system, but also we were able to look at the impact financially on families, and it's much cheaper for them to be managing their children at home as well. To remain cost effective, the number actually needed to be transferred home to the program was 11%. And if you may remember from my earlier slide, we just made that magic 11% number. We sent 12% home. Ideally, we were aiming for higher than that. The program was also rapidly implemented across the UK in 14 centres during COVID. And I neglected to mention that we were doing this implementation piece of work during COVID. So it was probably much easier than the last talk that I had to explain the new circuits for can't transplant patients via Zoom. But we had to do a lot of this via Zoom. And the toolkit that we developed for the implementation pathway was used throughout the UK to implement the program over there. And they've got some data that they've published. So they were almost half of the patients home on oral antibiotics within 24 hours and had a nice reassuring readmission rate. We used the consolidated framework of implementation research to try and look at all the enablers and barriers to implementing a new model of care. Obviously, the COVID pandemic made things quite challenging. But I think the two, and we've done post implementation interviews with all the sites, I think that probably the two biggest consistent issues across all the sites are just that shifting, the practice that's been happening for decades of keeping patients in and waiting for count recovery on antibiotics, and combining those fixed views with a rotating junior medical workforce that you can educate everyone about the new program, and then you get a new influx of doctors and have to start again. And it's just the time that takes, and certainly we, that some periods of time throughout the year there would be much higher rates of patients going home, depending on the level of time and engagement from the more junior staff. So by now, after we've done these series of projects across the country, we now have a database of over 2,200 prospectively collected febrile neutropenia episodes in paediatric patients. And we've been able to use at various times along the way these data to answer some other questions. So an important one, certainly in our micro lab, is what is the diagnostic yield of daily blood cultures in a patient that's clinically stable but persistently febrile after 48 hours. And we were able to look at what percent of blood cultures were positive over what time period. So 75% of our blood cultures in this cohort were positive in 24 hours. And the persistent fever patients had with blood cultures taken after 48 hours, had a very low diagnostic yield, less than 1%. And things that we were picking up were coag-negative staph and probably contaminants anyway. And all that does is commit a patient to a round of vancomycin before we confirm that. So the area where we did find a difference, and it was up around 13% diagnostic rate, yield in blood cultures were in the patients that had become febrile and were well, and then got a new fever episode during that same period of neutropenia, even if they were still on their pip-tabs, for instance. And that's not surprising. They've got a breakthrough bacteremia that's made them febrile. Brendan McMullen, in his PhD, used the database to look at the outcome of addition of aminoglycoside in patients that amikacin or gentamicin, for instance, in patients that had received either cefepime or piptaz as part of their febrile neutropenia treatment. And what he found was non-compliance with aminoglycoside prescribing was really common across the country. And even after adjusting, and we did this many times because we didn't quite believe what we were seeing, that the adjusted hazard of poor outcome was 3.8 times higher for those patients that had been prescribed empiric aminoglycoside. And we adjusted for things that you would expect that someone's on the trajectory to have a poor outcome, and that's why they would get their aminoglycoside. So severe sepsis, underlying disease, location, age, etc. So no matter which way we looked at the data and the propensity scores that matching that was done, we still found this signal of worse outcome in patients that received aminoglycosides. And then we looked at the patients that would have qualified for aminoglycosides but didn't get them, and those patients seemed to be doing okay. And this is the data here, I guess we shouldn't be that surprised about, because certainly in adults there's RCT level evidence of patients in febrile neutropenia with aminoglycosides, in addition to the broad spectrum beta-lactam having a worse outcome. The other interesting question we were able to look at in this data set was the impact of time to first dose antibiotic on adverse outcome in febrile neutropenia. And this is a topic that's probably getting a bit more focus more recently. So obviously, in the last decade or so, there's been a real shift and a push for that magic antibiotic administration within an hour in patients with severe sepsis. So the Kumar Crick Care study, the major paper that showed that significant reduction, increase in adverse outcome in every half an hour of delay of antibiotic, but they were in ICU patients with severe sepsis and septic shock. But that kind of that messaging is really spilled out into all aspects of our management of patients with potential infection, including febrile neutropenia in adults and pediatrics. So we were able to look at this question. We defined adverse outcome in this as ICU admission or death. And we wanted to adjust for factors that might influence whether or not you were administered antibiotics within 60 minutes or after 60 minutes. And we used a target trial emulation framework. I don't know if anyone is particularly familiar with that, and certainly I wasn't until my statistician raised it as a suitable framework for these kind of data. It's essentially you write up the ideal randomized controlled trial that you would use to answer the question, and then you use observational data to map out and emulate the trial that you were wanting to do. And it's helpful, particularly where it might be unethical, for instance, to do a trial. And I would I guess that it's quite unethical to delay antibiotics in a patient standing there with febrile neutropenia. But interestingly, after adjusting for age, sex, study site, disease and chemo intensity, and a very quite a robust definition of being clinically unwell at presentation, we found that febrile neutropenia episodes with time to antibiotic greater than 60 minutes, we really didn't show any difference in outcome when their antibiotics were administered. However, a limiting factor in the interpretation of this, that overall our adverse event rate was low, only 3%, and that everyone around the country is actually very good at getting the antibiotics in. So 92% of the patients have had their antibiotics in within 2 hours. So we could interpret this that there doesn't appear to be a difference in outcome in patients, even after adjusting for being unwell, that are administered antibiotics within 2 hours. It doesn't seem to impact whether they have an increased risk of ICU admission. And we broke it up and stratified the analyses into all the eligible FebNeut episodes, because we enrolled patients that had a neutrophil count less than 1. We restricted to ones that we had a known neutrophil count of 0.5 at the time of entry into the study. And that, again, it was on the side of the risk ratio was actually on the side of a lower risk of adverse outcome, again, with wide confidence intervals. I thought for sure we would see a difference in patients that had a confirmed bacteremia subsequently. again, we didn't see a difference there in those patients. The only time that we started to see a trend towards what I would expect an increased risk of adverse outcome in the patients where we had a known onset of fever at home that had their first dose antibody. And we did the analysis in greater than 3 hours or less than 3 hours. And you can see there that the risk ratio crosses one to the side of a higher risk of adverse outcome in those patients. These data were presented at the ANZCHOG annual scientific meeting in 2024, and I did an audience poll, and this is obviously non-binding and doesn't mean that we're going to be changing anything quickly, but 61 people voted on that. And you can see that there's a 50-50 split between no way, leave the targets of less than 60 minutes as they are, and just over half of the patients saying, yep, we should do something. I'm not sure what it is, some sort of risk stratification process. And certainly these data are in keeping with studies that have come out of Europe and also studies that have a large study in the US. And the study in the US has actually influenced the reporting that hospitals have to do about target time to antibiotics for their paediatric oncology patients. And then just finally, in the last few minutes, the study that we're running now is the ELSA trial, the early versus late stopping of antibiotics in high-risk febrile neutropenia. So all that time that I'd been spending in the preceding years on targeting the lower-risk febrile neutropenia patients, when we went back and looked at those typical high-risk patients that the AML diagnosis, the dose-intense therapy of ALL, the transplant patients that were expected to have neutropenia period for longer than 7 to 14 days, their antibiotic durations were really blowing out to, for AMLs, a median of out to 10 days, overall a median of 6 days. And these were in patients that had become afebrile within 48 hours, had negative blood cultures, but remained neutropenic. And so these information informed our randomized trial of randomizing patients to stopping antibiotics at afebrile 48 hours, irrespective of neutrophil count, versus standard of care. The quite cool thing about this, it's fully embedded into the EPIC electronic medical record. The EPIC system is able to screen patients continuously that might be suitable for consent, pops up alerts to clinicians to consent. Once they're consented, they're in screening. It notifies us when a patient has met inclusion and exclusion criteria for randomization. And then if they're randomized to the stop arm, the clinicians get alert to stop the antibiotics. And the EPIC system is our research database. So all the outcome, the primary outcome and all the secondary outcomes are going to just be extracted automatically from EPIC. So a summary, I guess, of the FebNeut research today is that home-based management of low-risk FebNeut is safe and improved quality of life and is cost-effective. The Oz rule has been used successfully across Australia and UK to help with that early discharge. Daily blood cultures after 48 hours have low diagnostic yield. Aminoglycosides in febrile neutropenia in our cohort have been associated with poorer outcome. There's no evidence that time to antibiotic greater than 60 minutes from hospital triage, but within 2 hours, that's an important caveat, increases the risk of adverse outcome, and we're addressing that duration of antibiotics in the ELSA-FN trial. A couple of other things that the team that I work with have been working on. We heard from Daniel earlier today and his incredible amount of work in the fungal infection space. Dan's over the years has built up a really amazing database of, really comprehensive database of fungal infections in the leukemia population. We're developing an automated invasive fungal infection surveillance tool that's being led out of the National Centre for Infections in Cancer, and Anna Kina is a PhD student on that. I've had the pleasure of working with Dr. Hannah Walker, who's an oncologist at the Children's Hospital, on her PhD, and she's looking at the impact, the epidemiology of pulmonary complications in transplant patients, and a prospective study of sampling BALs in these patients pre and post stem cell transplant to look at, obviously I'm quite interested in the infected causes of deterioration and complication, but she's looking at the inflammatory profiles in these patients as well. And then also using her database to look at viral reactivations and Dan's database to look at viral reactivations in the leukemia cohort and also in the stem cell transplant cohort. And we're just working up a letermovir prophylaxis trial. It's an international study, but we'll use that target trial framework as well that I mentioned earlier. And with that, there's a huge number of people to acknowledge that I've worked with over the years and have contributed data. Julia Clark and I have worked together for many years on many of these studies, and look forward to continuing to work with everyone for many more years. So thank you.